Hello everyone, welcome to another episode of podcast where we dive into the eco-guided life support from an Australian perspective. Our guest today is a trailblazer in the field of eco-guided life support, none other than Dr. Allan Whitehead. Allan is a renowned emergency medicine specialist in Australia, a celebrated educator and an innovator who has transformed how we approach critically unwell patients with the use of point-of-care ultrasound. With over 20 years of experience saving lives, he is here to share the insights from cutting-edge technology of ultrasound in terms of eco-guided life support. Allan has trained hundreds of doctors, nurses, medical students, and paramedics over the years in ultrasound. Please join me welcoming the extraordinary Dr. Allan Whitehead.
I am so excited. This is going to be a great opportunity. I can't wait to get started. Amazing.
Thanks for sharing your interesting cases. Now, Allan, you have been working in Australia for quite a while. What is your perspective from Australian point of view in case of this eco in life support? You have seen from the beginning till date.
So yeah, I think I was an intern in Dandenong Hospital in 1992, so that's probably showing my age. I think, a lot of people, and, you've got to give credit to, some of the godfathers of point-of-care ultrasound, like Justin Bauer as well in Australasia. They've been pushing this line of getting echo and ultrasound into the ACLS algorithms for 10, 15 years, so it's been a very, very slow burn. I think, it's still a slow burn. It's, to me, I'm not sure what you've seen, but to me, it's still used in a very underwhelming percentage of cardiac arrest scenarios, an underwhelming percentage of shocked patients. Everyone wants to put the probe on when there's a trauma case, it seems, but the cardiac arrests and the shock patients are still missing out a lot, in my view. And then no one's putting the probe on the stable patients. And as I said, there's a lot of, important findings that could be found in those patients. And then they're getting sent home without those things being found, sometimes to a very bad outcome. So, we definitely, I think, need to get the probe on more sick patients. Now, in a cardiac arrest, we sort of talked about, you just got to be really careful. You've got to be practiced. You've got to be experienced. You've got to have a certain number of cases on your belt, because it's all about being efficient and getting it done in under 10 seconds and getting adequate images. Now, when it's a shocked patient, you can play a little bit more. But, I'm still trying to perform my shock protocols, whether that's an EGLS protocol that works perfectly well for shock, and it's actually supported to be used for both shock and cardiac arrest. I'm also, to give Justin and his team in Sydney credit there, I'm also probably starting to use the SLICE protocol more, that's been published in the last couple of years, and the RUSH is very well known. So I think that we need to get these protocols being applied by people who are being taught, and that will benefit our patients. It's hard to make a case that sending a patient with a large pericardial effusion home is a good thing. It's hard to make a case that delaying the diagnosis of some of those cases that you saw before is going to be to their benefit in terms of getting the correct diagnosis and the correct treatment. Yes, it's all anecdotal, and it's hard to point to absolutely robust evidence.
Yeah, I think it is a bit of a catch-22 situation, isn't it? So on one hand, we are not using this every time, and on the other hand, we are saying that, we don't have much evidence.
Well, my counter-argument to that is, where's the evidence that what we're doing already is actually reliable and beneficial? So when people pull out that 200-year-old instrument, and I like to be frank when we're talking about the historical teaching in universities, They may not like it if they hear this, but I think we're stuck in the past too much, and unfortunately, the university system in Australasia is not helping because we are not getting people coming out that have the core basic ultrasound skills, which would then make it easier for us to polish them. So they're really good when it comes to these shocked patients and arrested patients, and they're efficient. But that most of them are not coming out with any ultrasound skills at all. And, that's because they're stuck with this historical concept that if you put the 200-year-old stethoscope on their chest and do a typical textbook history and physical examination, it's going to give you the answer. There's no evidence it's going to give you the answer reliably in your undifferentiated elderly shortness of breath or chest pain or syncope or abdominal pain. And if you put the probe on, this has been studied by people like Bruce Kimura of the CLUE exam, who's a cardiologist in San Diego. You improve your diagnosis accuracy by about 20 to 25%, from on average 50% to about 70 to 75%. No one's going to be 85 or 90 or 100, but I would rather be the person that gets it right 3/4 of the time by putting the probe on everyone. And I know that sounds unachievable, but if you use protocols and you practice, then I'm firmly of the belief that you can be doing these scans in under 5 minutes, which is nothing. And if they're stable, you can talk to them at the same time. So it's probably only taking an extra 2 or 3 minutes. So every time I teach, I'm really pushing, learn protocols, learn like half a dozen protocols, for cardiac arrest, your EGLS, for shock, you're either your EGLS or your rush or your slice, just to name a few. For your stable patients, maybe a CLUE exam or a radius exam. And then for your trauma, we have EFAST. Everyone buys into EFAST for trauma. Well, I think they should be buying in for protocols for non-trauma patients as well. What do you reckon, Avijit?
Yeah, I think I agree with that. Of course, there are different types of protocols, and we need to use that judiciously. With regards to the university, as you have rightly said, that I think we are progressing very slowly, and you are trying, and also I am trying to streamline the whole process in universities. But the good thing is that gradually it is getting there. It is a very slow process, but slowly we are getting there. And I'm very hopeful that over the next 5 or 10 years, things will be dramatically changed. And once we get these young doctors trained in echo or ultrasound, when they become clinicians, they will be more confident clinicians than those using solely the stethoscope.
Yeah, we just have to look at America. And I know we're always behind America in everything in medicine. But, in American medical schools, 80% of medical schools are teaching ultrasound somewhere in their curriculum now. So we're probably, I would estimate, it's not even been measured in Australasia, but I would estimate it's probably more like under 10% here. And I agree with you. There's always early adopters. There's always the group in the middle. There's always the late adopters or laggards, right? And you hope that the early adopters sort of almost embarrass the laggards into sort of picking it up. But we all know the two issues at the moment that I always strike, and I'm sure you've heard them, is there's no money and there's no space in the curriculum. So they're really hard hurdles to get past. But I would hope that the demand comes from the students themselves as well, that they sort of knock down the doors of the people writing the curriculum and say, hey, I'm paying tens of thousands of dollars, sometimes hundreds of thousands of dollars to be a medical student here. How about you do some of the things that I actually think are valuable?
And that is very important. And I do some training of the medical students, and amount of enthusiasm and interest they have, that is really good. That's a very good sign. And they are taking this ultrasound skills in their knowledge base. And I'm pretty sure when they become clinicians, they will be able to get more skills and more training, and they will be a better clinician than those who are not using this.
Which sort of overlaps with your next heading, doesn't it? Ultrasound equipment.
So you have demonstrated a few cases where you use the handheld devices. Tell us a little bit more about it. What are the equipments you feel are appropriate for these type of scenarios, especially when there is time critical and life-threatening emergencies like cardiac arrest or peri-arrest scenarios?
Yeah, well, my first case was more of a traditional cart or laptop machine, and the second case was a handheld. I think in the arrest situation or the shocked situation, at least initially, these are big picture problems. They're not going to be subtle what's going on with a patient to affect them that much. So, you don't need to over measure. It's a qualitative thing. It's a big picture questions you're trying to answer. I like Christopher Moore from Yale, emergency physician, and Rachel Liu. They're fantastic teachers if you ever get the chance to go over there and do one of their POCUS courses that they run for a couple of times a year. I'm not getting paid to say that, by the way, but I have done their courses and been an instructor. But anyway, the reason I mentioned Christopher Moore is because he and others published on this thing called 5 E's, which you probably heard about, Avijit. And yes. I really like that when I'm looking at the heart and I've got a really sick patient in front of me and I'm doing the heart bit either in a cardiac arrest or shock. And obviously, if it's cardiac arrest, I've recorded my best clips subcostally typically, and then I pull it aside and I'm trying to answer the 5 E's. Now, if we talk about the subcostal one, we can get 4 of the 5 E's. We can get effusion, doesn't matter the order. So effusion, 1E. We can get equality, RV to LV ratio. We can get ejection, which is the LV squeeze. And we can get entry, which is the IVC. If you quickly rotate onto the IVC and see if it's dilated and not collapsing much, or is it thin and almost kissing, collapsing a lot. So that's 4 of the 5 E's. The 5th E, by the way, is exit, which is aortic root, which you can really only get well from the parasternal long view. But that's 4 of your 5 E's, which is going to give you a hell of a lot of information in your cardiac arrest. And when you're doing a shock patients, you probably, for me, I really do like getting that parasternal long and short window as well. For the aortic root, the rule of 3, which we've mentioned earlier, and also the D sign, preferentially from the parasternal window because it's a bit closer, but obviously I can do it from subcostal as well. So yeah, I'm sort of thinking those. In terms of equipment, you use what you've got. I mean, to be honest, I just said it. It's better than a stethoscope, for God's sake. And, these days, handheld ultrasounds, depending on which one you buy, they're anywhere between, Australian dollars, say $4,500 to $9,000 in that sort of price range. So certainly most consultants can afford that. And, it's tax deductible. And so I personally think that we should be seriously thinking about bringing our own device to patients. Now, obviously, there's different issues around what your hospital will permit and stuff like that and saving the images. But where possible, it's not a bad thing because I think you'll scan more because you're not looking for the machine and wasting the machine and fighting once with someone else for the machine. Mm-hmm. And you can bring it easily with you. Certainly handheld, you can bring it easily with you. You look at the triage note on the computer and it says chest pain or shortness of breath, you should be applying it, or abdominal pain, and you bring it with you and you start talking to the patient and scanning them at the same time. And I think you'll scan more, you'll scan faster because you're not wasting time. They also tend to boot up a little bit faster than your classic cart and laptop machines. So, and in that crowded situation, and I work in I've worked in places where the department is very old, and so the cubicles are small. And these days, people are getting bigger and bigger as well. And having a couple of doctors and a couple of nurses and a couple of IV trolleys, maybe a central line trolley, an anesthetic trolley, and there's just no room left. And then the patient's sick, and you can't get the ultrasound machine in there, even if you have a laptop or a cart. So being able to reach in from any spot with the handheld, I find is very useful.
And recently they have got this wireless device that you don't need even a wire. So you can just use the wireless ultrasound device with a very small probe with you in your phone or something. And some of these devices also started, I saw that they use a Doppler. Previously there was a Doppler, now they can use a Doppler as well.
Yeah, most of them now have a pulse wave Doppler if you want to do that, yeah. But I mean, when we're talking about the sick these really sick patients, usually, and in my view, when at the heart is a good 2D or B mode picture is going to give you a hell of a lot of information. And at least in your initial assessment, that's probably all you need. If you're trying to maybe, if the patient's sort of, if you stabilize the patient a bit, or at least they're still surviving for a while, then you can sort of start to finesse things like volume responsiveness and maybe check out the valves a bit more if you're worried about, say, you know, an acutely blown valve and things like that. But that's probably not right at the start, because you're just getting those big picture diagnoses and big picture therapies in.
Yes.
But we're jumping around a bit, and we're overlapping with things we might talk about later. But I think that the initial ultrasound, you can train yourself to a level where, you know, you can answer questions about how good is the squeeze of the heart, what's the IVC doing, is it thin and collapsing a lot, is it dilated and barely collapsing, are the lungs dry or the lungs wet? And that's going to give you a bit of solid ground to decide how aggressive you want to be with your volume resuscitation. Because I think one of the concerns I really have around the current sepsis guidelines and shock guidelines is, you know, this 30 mils per kilo straight up bang in as fast as you can, because potentially that does a lot of damage to someone with a bad heart. And even worse if their lungs are already wet as well. And it's, you know, it might overall be a good thing, but for the individual patient in front of you, it can be quite harmful.
Absolutely. So we talked about this a little bit, training of the clinicians. We talked about training of the medical students and also the doctors. I know that you are actively involved in the training of doctors, nurses, paramedics, and medical students. Tell us a little bit more what is going on at this moment and what we can do from here.
So I'm Victorian based. So I've actually got appointments at all three of the Victorian medical schools as it happens at the moment. But that doesn't mean that, you know, there's a lot of medical school teaching. But give credit where credit's due, I think. And, you know, I've got kids that I would, you know, if they wanted to do medicine, I know which university I would be directing them to. I would be directing them to the University of Melbourne, purely because there's more ultrasound in that medical school than pretty much anywhere else in Australasia at the moment. And that's a great thing from my point of view. Obviously, I'm biased. I love POCUS. But I still think that even from the point of view of not only the clinical benefit, but also what about their learning for anatomy and physiology? What about making it safer for them to do procedural skills rather than stick needles in blindly, and also making it better for them when they're trying to do needle guidance for peripheral vascular access on these very difficult patients? I mean, even if we say just, you know, needle guidance for peripheral vascular access and anatomy and physiology learning, surely ultrasound is a good thing for those. I mean, there's a lot of, I think there's good evidence base to support those aspects. So in terms of training, I'm sure we talk about this all the time about how do you train up doctors and how do you train up students? I mean, we're probably talking about this more at the doctor level, but I've certainly had one or two really passionate students that have gone on and, you know, done certification. They're so passionate about it. And there aren't a lot of options in Australia or even internationally, are there? I mean, we're not talking about people who know they want to be a sonographer and they go down that pathway. We're talking about people that have got an MD or an MBBS and then they want to get some sort of ultrasound training. Should I declare that, you know, I'm employed by one of the private training providers here, Avijit?
Yeah, sure.
Yeah, it's probably a good thing. Just so you know, so it's out on the table. I currently I'm a permanent part-time employee with Zeta Ultrasound Training Solutions in Melbourne. So I do that 1 or 2 days a week, and I really enjoy it. So I also did some university teaching, not as much as I would like. Now, in terms of training, you know, it's where do you start? It's a hard one to start, but for emergency, let's stay with emergency medicine doctors because that's who we're talking about. The college, and Avijit sort of got the college logo up there for Australasian College for Emergency Medicine. They have sort of guidelines and recommendations, but nothing's really mandatory. But it does it reflects very similarly the Australasian Society for Ultrasound in Medicine, the CCPU, or Certificate in Clinician Performed Ultrasound. And that would probably be the most common certification that doctors in Australasia have at the moment. There are some university-based qualifications as well, both in New Zealand and in Australia, in Melbourne at the moment. But that would probably be the most common one, the ASUM CCPU, and it's modular, which makes it quite handy. And I think it does give people a bit of a solid grounding. I'm not sure about you, Abhijit, but I would recommend that they at least get them, that they either do the ASUM CCPU or they do something that's equivalent to that in terms of a logbook and the number of positives and some formative and summative assessments. Because, as I said, we're talking about trying to perform ultrasound in a very stressful situation when you've got a shocked or arrested patient. And I think you've got to have a certain number under your belt to be able to do that with confidence. And I think, you could pick any number, couldn't you, Abhijit, whether it's 25 or 50, but I don't think most people are going to say that you could do it at 5 or 10 cases. So you've got to pick a number. And I think, even if you decide not to go down a pathway that gives you some letters after your name, at least matching what they expect and keeping a little notebook with your own cases that you've logged, and then going and checking against, a formal echo or a CT or whatever it happens to be, and getting some people that are supportive to have a look at your images from time to time and try to give you a little bit of feedback. I mean, do something like that, and you're well on the way. If you've got enough passion about it and drive, you will be able to find people that will be supportive, and you can, to a degree, teach yourself. The problem is you're going to probably be a little slower along that path because you don't have people to give you the feedback and guide you. And it is possible to do it yourself, but I would encourage you to do either an ASUM CCPU or at least something equivalent to that informally, like what ACM recommends, or just doing it totally informally yourself, but going through that process of logging cases and checking against, the lung ultrasound can be checked against the chest X-ray to start with, and having a process where you at least keep a record and audit yourself.
Yeah, I completely agree with you. I think it's the most important thing is the interest and enthusiasm and self-learning. That's the best learning. If somebody wants to get some qualification, there are a lot of resources out there. There is university qualification from University of Melbourne. In New Zealand, there are university qualifications. And also there are a lot of courses. CCPU is a very good thing to start with. But at the end of the day, this is not the number. This is not the logbook. Logbook is just a number. What is most important is the confidence and expertise that somebody has. This is the level of application of this knowledge to clinical practice. That what will matter, rather than I have done 20 cases or 30 cases. In case of the Australasian College for Emergency Medicine, it has made mandatory for the trainees, but this is very basic level of ultrasound. It is just to give some basic foundational knowledge, and if somebody gets interested, they can get further expertise, further training later on. That is the main idea. Unfortunately, the ACEM does not advocate or has the ability to train the FACEMs. That is the interest of the FACEMs or the consultants to get the training by themselves. So this particular screenshot, this is directly from the college. The good thing is that even if somebody like a medical student is not a member of the Australasian College for Emergency Medicine, they can log into this, they can apply for the ultrasound modules, and they can do all the modules by themselves. So it will give a very good foundational knowledge and some advanced knowledge as well. And then they can do some training from ZEDU or somewhere else. And of course, it needs to be practiced. And this is the practice that will make somebody a better clinician.
And even if you've got a certification, whether it's ASUM, CCPU, or university-based, it's like your CPD. You've still got to keep ongoing logging cases. I'm still keeping record of my cases and auditing myself every year.
Yeah.
For the benefit of my CPD as well, but also just to make sure that, you know, I'm getting a reasonable number of the different types of cases, and, you know, comparing myself against, you know, other imaging standards. It's a healthy thing, you know. It's all about that lifelong learning. So, you know, I think that's one thing I would definitely say. It's not just, you know, a single point in time. I'm a better scanner than I was 5 or 10 years ago because I'm still learning. And teaching, actually, I would, you know, what do they say? You know, you understand something better if you teach it yourself, right? So
Yeah.
as you get on, I think teaching helps you learn. And also it's good to give back, you know, like help people. And that's where I think the other two things that people can go to for help is a lot of accredited emergency departments. 75%, I think, was the figure that ACM quotes, have a clinical lead in ultrasound now. Now, unfortunately, they don't necessarily get enough hours to do that job because it's not mandated. But it does mean there's nominally someone there most of the time in a lot of EDs that has that portfolio. So they're a good resource to go and tap them on the shoulder and say, what can you do to help me along my pathway with ultrasound? And maybe join in when there's like workshops being run and stuff like that on site, find out about them. And the other resource, without giving them, you know, a plug, and again, it's a not-for-profit, so I don't feel guilty about that, is eMugs is a good resource to be aware of, emergency medicine ultrasound groups.org, because they're really probably the biggest POCUS organization in Australasia, mostly emergency focused, both doctors and sonographers, which I think is a strength. And they're running conference every year. They're running courses and workshops, including EGLS, by the way, which is what we're talking about today. And also, you know, there's good, like, online. If you go online, it also fills you in with what educational opportunities there are. And you get to know sort of eMugs people in your region as well. And everyone, eMugs community, isn't it? The POCUS community in Australasia is a very friendly community. If you ask someone, most of the time they really will help you.
Excellent, thank you. And for those who are not aware, Allan is the master instructor for eco-guided life support in Australia. So we touched base a little bit about this, Allan, about the challenges and limitations. Obviously, one of the big challenges is the training and the lack of resources. Is there anything else that you would like to talk about?
Well, I think basic cardiac ultrasound, in one way you can say it's possibly one of the more challenging ones to get the images. It's maybe not as easy as the EFAST, because trying to see a liver or a spleen or a kidney, or maybe the lung in between the ribs, they're big organs, they don't move that much. So not so technically challenging getting the pictures. Whereas the precordial views, the apical and parasternal, can be more challenging. The probe moves need to be smaller and finer. You're trying to shoot between the ribs. It's a smaller target. It's moving a bit on you. So technically, it is potentially a bit harder. Although when you do the EFAST, that's why I really like the Monash Health. To give them credit, I used to be an employee of Monash Health. And I really like their idea for diagnostic, that they start the first diagnostic POCUS module they teach their emergency trainees and senior residents is the EFAST module, because I think it's such a good scaffold and groundwork. And guess what? It gives you the subcostal cardiac view at one of your 3 standard cardiac windows and your key window in cardiac arrest, and answering that question around pericardial effusion. So that window, not so hard. The precordial one's a little bit harder. But on the other hand, I can point to some evidence and articles where in 2012, there was a landmark study where they took a group of medical students in the US and they were probe naive. They'd never touched a probe before, 4th-year medical students, which is unusual these days. And they took them for 7 hours of didactic on one day, 7 hours of hands-on on the next day, just rotating around some stations. So just 2 days, just basic cardiac ultrasound. And then what they did was, and you'll get a kick out of this if you haven't heard this story before, is they pitted them against 20-year veteran cardiologists with their 200-year-old instruments, their stethoscopes, and their traditional history and physical examination on the same day, again, on the same patients in the same coronary care unit. And they asked them, what's wrong heart-wise with the patient? And the gold standard was a formal echo done later that day. And the accuracy of the medical students, well, let's go with the accuracy of cardiologists. Let's reveal that one first. Again, when I said it's really toss of a coin, 50% for the traditional method of assessment, guess what? 49% for veteran cardiologists using their stethoscope on these coronary care patients. Medical students with just 2 days of teaching, they'd never touched a probe before, 79%. Not even close. I mean, if that doesn't convince you, we're on the wrong pathway with what we've been doing for the last 30 or 40 years and still doing it. I don't know what will, but unfortunately, when I try to convince the curriculum heads and the deans of this and to point to these articles, it still doesn't sway them. But, it's sort of hard, but it's not as hard as what you think, especially if you're trying to answer big picture questions. And I suppose the challenge is getting the 10-second view, having that practice that you can do that. I think another challenge is sometimes we're talking about, the training. I think we were going to get into talking about the challenges about providing the training on site. That can be hard. You can go and people can do some external training with organizations, universities. But you've also, if you try to do it yourself, you've got, there's costs to pay instructors or costs if you go outside to pay for that. There's costs for, sourcing equipment if you've got to buy more equipment, or if you're loaning the equipment, that can be hard to, where do you get more machines from? Do you take them off the floor and then they're needed clinically? Do you loan them? That's becoming harder because everyone wants to loan machines from the ultrasound companies. Do you buy more machines? Well, where are you going to get the money? And sometimes the other thing that happens is you've got machines that don't have a cardiac probe, or they loan you one that doesn't have a cardiac probe. So I think, sometimes I'm thinking personally, my view is when you're trying to teach people more of the basic stuff and you're trying to set up maybe some in-house workshops, maybe instead of spending, tens of thousands of dollars, so, $40,000 to $70,000 or $80,000 on one cart that you are going to dedicate to your education and your ultrasound POCUS teaching at workshops, maybe you're better off buying, maybe a secondhand cart or laptop type machine or tablet type machine on a stand, and then throwing in a few handhelds. Because then you get more probes in hands. And I'm sure, Avijit, you know what you said, where the students can't get enough of it. It's the same with the junior doctors and the registrars. They can't get enough, and they would rather have more time on the probe, even if it's a less fancy machine.
Exactly, completely agree with you. I don't know if you have come across this article that was recently published. I think it was just published in March this year by Adrian Gowdy of Perth and Michael Blavers from the US. They wrote it as a commentary. It's not a research paper, but they summarized this different Resuscitation Council guidelines from Europe, American Heart Association, and Australia, New Zealand. And they are portraying a picture which is not very enthusiastic. They are suggesting that, first of all, ILCOR does not recommend use of ultrasound for prognostication. We can still use ultrasound or echo during the cardiac arrest, but not for prognostication and not for the sole indicator for termination of CPR. From European side also, they are saying almost similar thing, that it needs to be done by the skilled operator. We talked about it, that the most experienced clinician should perform the echo, not a junior registrar. And in Australia, New Zealand, they are saying that we should do the echo, but it should not interfere the standard ALS algorithm. What are your thoughts about this paper, Allan?
Well, I'm not, I mean, a couple of these people I know, and they're eminent in their field of POCUS, point of care ultrasound, both in the United States and also in Australia. So I would always be reluctant to disagree with them, because I have a massive amount of respect for the two that I know, which is Adrian Gowdy and Mike Blavis, and I'm sure the others are highly respected in the field as well. What I think is, I'm not disagreeing with what was said. I don't use it as a sole data point. I use it as one of a number of data points. But on the other hand, I'm not so sure that it's the right thing to do to absolutely neglect it totally and wipe it off the slate as a data point, and totally ignore it. But it's one of a number of data points. The evidence isn't there that we can use it as a sole data point as at the moment. I agree with that. But on the other hand, that's not the same thing as saying that you can't use it as one of multiple data points. And the other thing is that I haven't seen it myself, but I've seen, images in books and stuff as well, is if you see a left ventricle that's totally full of clot, like totally full of clot, and there's no runny blood anywhere, it's just full of clot, that implies that heart has been static for a long time. And that's not, I don't think anyone's ever shown that's a survivable situation. You can't give enough thrombolysis to resolve that. And on top of that, it means the heart's been static for so long that all the other organs are, compromised as well. So there are always extremes. I haven't seen one of those myself, but if I saw that, I think I would be stopping.
Yeah, I think I agree with that. Although there are different guidelines from different authorities, at the end of the day, as a clinician, we need to we are seeing the patient, and we need to judge ourselves what is for the best interest of the patient. If we see a large clot sitting there in the left ventricle, there is no point of continuing CPR.
I'm not just talking about like an intramural thrombus, that might flick off and do an arterial embolism. I'm talking about complete filling of the left ventricle with clot.
Yeah.
One of the other things I may have touched, probably missed talking about in terms of, limitations for the EGLS system in terms of the formal protocol is, I encourage people who don't know it to look at it. The article was written in 2011, and I think we should give credit to those people. They were 3 Canadian physicians of either emergency or critical care background. And it's a very robust protocol, well designed, I think. But it stops at the lungs and heart. It doesn't go beyond that. So I think that is a limitation, because sometimes you haven't got your answer there, or you've only got part of your answer there, especially around a hypovolemia situation. And so looking further afield, you really do need to look further afield. And that's where you sort of, I think, where I appropriate, moving towards and joining and switching courses and going into the rush protocol, for instance, to try and then answer that question. But on the other hand, EGLS, the formal course is a 1-day course. There's only so much you can teach in a 1-day course. And, it makes sense to concentrate on the basic cardiac and lung views in that day. But it is something you need to be aware of, that it doesn't move further if you haven't got your answer yet.
Yep. I think the eco-guided life support, they are updating their protocol. I don't know how much they are updating or exactly what, but I heard that they are going to update their protocol very soon, probably this year or next year. But we'll see what they come up with. So I'm pretty sure, Allan, you have seen a lot of this new technology, especially the artificial intelligence in echo. Have you noticed any change in how it affects the life support?
What I'd say is I still think that on the initial assessment, most of the decisions you're making are around your 2D or B mode pictures. Although there are some AI influences on both, I'm assuming, larger devices and machines, and also handhelds, where they are guiding you to potentially change your orientation of your probe to improve your picture. So that will potentially improve your 2D or B mode picture when you're struggling to get it or it's not quite right. And then there are different AI enhancements, whether that's an automated ejection fraction or automated B lines or automated IVC assessment and these sort of things. I'm not so sure that
VTI as well. I don't know if you have used that.
Yeah. I mean, these things I think can flow a little bit later depending on the direction of how the patient's going. I don't think they're necessarily as useful in the first assessment. And my concern is that you maybe are over measuring even with AI. It's taking you a bit longer even with AI than a sort of a rapid eyeball assessment. Again, it depends on, I think in a shocked patient, you've got a little bit more time to play and try and answer some more questions. In the cardiac arrest situation, you've got less than 10 seconds. I don't think AI is going to help you much in less than 10 seconds either, to be honest. So it does depend the type of patient. Certainly in the stable patients, I mean, Mike Blavis is, I think, discussed this as well, that there's the difficulty we talked about with university as well is, how do you teach all these new learners coming out? Is there the scope to develop enough instructors to cope with all the learners and what they need to know? And then AI is seen as a way of almost, as you said, self-learning, buying a device, having your own machine, and then the AI will actually guide you to improve your image acquisition and then help you with the interpretation. And I think that's going to happen to a degree. But I suppose, the technically difficult patient's still going to be the technically difficult patient. And sometimes the AI might try to guide you, but really the experienced pair of hands is still going to be better, or having someone watching over your shoulder might still help you get to the view that you're struggling with the AI telling you how to get the view. What's your experience with AI so far?
So far, I really like the artificial intelligence, especially in case of echo, VTI, the ejection fraction, the inferior vena cava compressibility or collapsibility index. But in cardiac arrest, I have never used it or found them useful. And as you have rightly said, this is eyeballing in cardiac arrest scenarios. That is good enough rather than doing some quantification. But in the patient is relatively stable, even in shock patient, those quantification, they can be very useful. And AI is really good in doing the quantification much quickly and more appropriately, I thought. That is my experience.
Yeah, I'm a basic to intermediate cardiac guy rather than an advanced cardiac guy. So I like to call it like more meat and potatoes. But I do sort of know how to do some, of the VTI and volume responsive, but I don't feel super comfortable doing it. And I think if the AI helps people like me feel more comfortable, when, as you said, in those patients that are still maybe stuck in your ED because they haven't moved to ICU, where some of those doctors can do it for you, and you're still managing them, or in my scenario, in a country hospital where I'm still waiting for them to be retrieved, so I still have to look after them. If I can start to, get more of those little finessing measures about, well, how much extra fluid can I give safely before I have to switch to inotropes, maybe that last 100 or 200 mils judgment before I go over the top of the Starling curve and start to cause problems. If that helps me, that's great. But, I think, and the absolute initial, the first decision on, how aggressive you can be with your fluids to start off, and a rough idea of how much you might be able to give. If I see, a heart that's squeezing well with dry lungs and an IVC that's thin and collapsing a lot, I know that I'm going to hit that patient pretty hard with fluids, probably at least the 15 mils per kilo straight in, maybe often the 30. On the other hand, if I see someone that's got, a floppy heart, really, severely impaired left ventricle with some wet lungs and a dilated overseer, I'm probably not going to give them any fluid at all. And if the lungs are dry and the IVC is sort of normal to borderline dilated, I'm probably going to go, okay, let's just be cautious here. Let's maybe give 200, 250 mils and reassess, and then start to use that volume responsiveness stuff in those patients with the abnormal heart or the abnormal kidneys or both, where it's really tricky around volume. I think AI will help people like me who are less confident around those things.
Thanks, Allan, for sharing. We are nearing the end of the podcast. So what will be your final advice to the healthcare professionals who are using the echo in life support, Allan?
So I think sharing a personal story around EGLS, it's probably not so much around EGLS. I actually want to come back to the idea about using it more for stable patients. I know it's an EGLS talk, but there's a hell of a lot of people that you can benefit out there who are stable in your practice, whether it's a moderate or large pericardial effusion that's getting missed, whether it's a severely impaired left ventricle that no one knew they had, including young people who've unfortunately poisoned their hearts with drugs, or old people where it's never been diagnosed before, whether it's a stable PE patient on a seat with a CTPA who's got strain that would have got sent home, and they probably shouldn't get sent home while they got evidence of RV strain, whether it's a patient with resolved anterior posterior chest pain who sounds like every other patient in the short stay who you put the probe on and see a dilated aortic root. Those are the things that, I get a lot of satisfaction out of, because I don't get as many cardiac arrests or shock patients, but I get a hell of a lot of these stable patients. And I reckon 1 out of every 10 or 20, I find something that I wasn't expecting or that was worse than I was expecting that totally changes my diagnosis and management. And there's certainly evolving literature around how often is the ultrasound changing what you thought was going on and changing your management, whether that's in an ED setting or an ICU setting, or even an inpatient. There's literature around patients being sent home from both the ED or inpatient, say, renal wards, and they were assumed to be dry. They'd got some treatment. And then as part of the study, they ultrasounded them before they were going to be sent home. And sometimes they didn't intervene. They just let standard practice happen. And the lungs were still wet in 30% of those patients. And then 30% of the ones that they allowed to go home still wet, they bounced back within 48 hours with more fluid, because they weren't told to fluid restrict more or take more Lasix. It was undertreated. So these are the things that I think, are out there that we can really add a lot of value. So when I actually heard Bruce Kimura, the cardiologist from San Diego Mercy Scripps Tertiary Hospital, talk for the first time at an overseas conference in the US in about 2012 or 13, I think that changed my practice more than anything ever since, in terms of encouraging me to put the probe on and do basic cardiac and lung ultrasound, and teaching it to do it in an efficient manner with a protocol, his CLUE protocol, that only takes 2 to 3 to 4 minutes, and I can talk to the patient at the same time because they're stable. So that's my probably personal story about doing more basic cardiac and lung ultrasound. It isn't on the critically ill patients, but I also think that doing it on those stable patients and feeling that I have a system means that I've grown accustomed to the idea of having a protocol for a particular type of patient. So, I have, everyone knows about EFAST and trauma. I have a CLUE protocol for my stable chest pain and shortness of breath. I have a SLICE protocol for my shock patients and an EGLS protocol for my cardiac arrest. And I've got enough cases, because I'm doing it on, 4 or 5 or 6 of these stable patients every shift, that I know under pressure, I can get the view. I can have a good shot at getting the views. And I think question how you're historically taught. It really frustrates me that people are still taught that, this traditional history and physical examination and the stethoscope are reliable when there's no evidence that they're reliable. Just ask yourself, would you ever let someone stick a needle into your abdomen on the basis of shifting dullness? I just hope you say no. And don't let anyone stick a needle into a patient's of yours chest, or your chest on the basis of a chest x-ray, because that's very, very dangerous. You have no idea how much fluid's under there and whether there's a big mass or tumor, or a very consolidated lung or a diaphragmatic hernia or anything you can prang on that chest x-ray that looks like a large pleural effusion. So I think, question the traditional ways, and the same traditional thing around, well, fluids and epinephrine will solve everything in cardiac arrest. It won't solve everything. That's why the EGLS protocol is really a good idea, because its philosophy is the fastest thing you can fix is a pneumothorax with a needle. The second fastest thing you can fix is a tamponade with a needle. And then everything else is going to take longer to fix. And you can give fluids and adrenaline or epinephrine while you're trying to sort out what else is happening. But they're not going to help the patients with the pneumothorax or the tamponade. So I think, for me, that's probably the greatest advantage of that protocol, is it makes you think about those two things first.
Excellent. Thank you, Allan, for sharing that. So if we summarize everything, echo is a very important part of the advanced life support. How we use it and when we use it can be controversial, but at the end of the day, we can get a lot of information that actually can help the patient. The most experienced clinician should perform the echo during the advanced life support. And the way we can make a person most experienced is by training. The training can be done by attending courses, doing different programs from university. But at the end of the day, this is the personal interest and enthusiasm that can help one well-trained. We have got a lot of materials as a reference, and as Allan has rightly said, there was this article for the eco-guided life support, which is this article by Langtoft and Valois. This is a free article, so anybody can download it and read it. This has got the algorithmic aspect of use of echo in life support cases. Thank you, everyone. And thank you, Allan, for taking your time. It was great, very informative and very educational. I learned a lot of things from you, as usual. And I hope that we can see you again in another episode of podcast. Thank you very much.
Thanks, Avijit. You can see I get very passionate when I talk about POCUS like you. And this is my first ever podcast, so I really appreciate the opportunity. For an old person like me to actually do a podcast is a thrill.
No problem at all.